Welcome to the weekly Neurology Deep Dive.
Glad to be here.
Today we're diving into the NEUROGED guidelines. That's the European Academy of Neurology, EFES, and INEUS, focusing on neurogenic urinary and sexual symptoms.
Yes, specifically aiming for the practical takeaways for neurologists in clinic.
Exactly. And just a reminder, this is purely educational, no commercial goals here. It's a summary, so you really must read the full published paper for all the details.
Absolutely essential.
Our aim today is practical, actionable data numbers, percentages, criteria, things you can hopefully use almost immediately. Let's start with urinary symptoms. Assessment, where do we begin?
Right. The foundation really is history, proactively asking about urinary symptoms and doing it regularly.
Not just waiting for patients to bring it up.
Precisely. We need to cover storage symptoms, urgency, frequency, and nocturia, incontinence, different types too, urge, stress, continuous.
Even related to disability or sexual activity?
Yes, and voiding symptoms, hesitancy, stream quality, straining, incomplete emptying. Also post-micturition symptoms.
So a really detailed picture. Onset, course, treatments tried.
Complications like UTIs, hematuria, pain, lifestyle factors too. Fluid intake is a big one, smoking, alcohol. And always ask about bowel and sexual symptoms alongside urinary ones.
And comorbidities, quality of life impact. It's comprehensive.
It has to be. Then there's the physical exam.
What's key there?
It should be targeted for anyone reporting symptoms initially and then annually for those at moderate or high risk.
What does targeted involve?
Vital signs including orthostatic hypotension checks, a focused neuro exam cognition, motor, sensory, crucially the sacral innervation, S2 to S5.
Reflexes too, like anal and bulbocavernosus.
Exactly, and an external genitalia exam. If you suspect prostate issues or pelvic organ prolapse or maybe abnormal pelvic floor function, that's when you refer to a specialist.
Okay, what about basic tests? Urinalysis.
Definitely part of the initial workup and at follow-up if indicated, mainly to help rule out UTIs.
How reliable is the dipstick?
Well, in MS, for example, positive leukocytes and nitrites have about 78% sensitivity and 65% specificity for significant bacteria. That's usually defined as 100,000 CFU/ml or more.
So it's a pointer, not definitive.
Right. It flags suspicion if there are symptoms. Urine culture should only really be done if you suspect a UTI based on symptoms: dysuria, cloudy urine, pain, fever.
And not routinely in catheterized patients.
No, definitely not. The rate of asymptomatic bacteria is just too high.
What other non-invasive tools are useful?
A 3-day bladder diary is recommended. It gives objective data on intake, output, timing, urgency, incontinence. Really helpful initially and for tracking progress.
And post-void residual PVR.
Yes, PVR should be measured, ideally non-invasively like with the bladder scan, in anyone voiding spontaneously who has symptoms.
When is it considered elevated?
A consistent PVR above, say, 150 millibel is generally the cutoff to consider, though you have to look at the individual. It suggests potential voiding dysfunction that needs investigating further.
Makes sense. Renal function.
Assess blood urea and serum creatinine initially. Repeat if things change clinically or maybe annually for stable patients who are still considered at risk of upper tract damage.
And for men, PSA screening.
It may be offered for men aged 50 to 70 with neurological disease and urinary symptoms, but only after a proper discussion about the pros and cons.
How often?
Maybe every 2 to 4 years. You might start earlier, say 40, 45, for higher risk groups like those with Black ancestry or a strong family history.
Okay. When do we escalate to urodynamics?
It's not for initial evaluation. Referral for urodynamics comes in if symptoms are atypical, if there's a high risk for upper tract damage, or if conservative treatments just aren't working.
And it's first line for some.
Yes. For those moderate to high-risk individuals, think suprasacral spinal cord lesions, spina bifida. Urodynamics help figure out why there's dysfunction, like distinguishing detrusor overactivity from underactivity.
Crucial for treatment choices.
Yeah.
What are the main red flags for a urology referral?
Referral is key if you suspect upper tract damage risk or another urological issue, or if first-line treatments fail or cause significant side effects.
Specific examples.
Conditions like SCI, dysraphism, transverse myelitis, advanced MS, recurrent UTIs with fever, unexplained hematuria, loin pain that seems urinary, abnormal ultrasound findings, hydronephrosis, stones, diverticula.
And the high PVR again?
Yes, PVR consistently over 100, 150 millilo. Also, renal impairment or suspected prostate enlargement or pelvic organ prolapse.
Right, clear triggers. Let's shift to treatment strategies. What's foundational?
Starting simply, fluid intake advice. aiming for adequate intake, usually 1 to 2 liters for an average adult.
And avoiding irritants.
Yes, things like caffeine, fizzy drinks, citrus, alcohol can worsen storage symptoms, but be cautious with this advice in people prone to constipation, dehydration, or orthostatic hypotension.
What about behavioral therapies?
Bladder retraining, scheduled voiding with increasing intervals can be considered.
Who's it suitable for?
People with urgency who can void spontaneously are at low risk of upper tract damage and have enough cognitive function to follow the schedule.
And pelvic floor exercises.
Definitely advise those for urgency and/or stress incontinence. If the person has some voluntary pelvic floor control and low upper tract risk, referral to a specialist physio is best.
Okay, what if someone can't empty their bladder properly? High PVR.
Then intermittent catheterization, or IC, should be offered as first-line therapy if the PVR is consistently over 150 millil or in retention.
After discussing risks and benefits, of course.
Absolutely. And proper training on technique, clean or aseptic by a healthcare professional is vital.
What if IC isn't feasible long-term?
If long-term drainage is unavoidable, a suprapubic catheter is generally preferred over urethral. Lower complication risk, but it's a shared decision.
Antibiotics for catheter users? Prophylaxis?
Routine prophylaxis isn't recommended. Better to find and fix underlying causes of recurrent UTIs like stones or poor technique.
But sometimes prophylaxis is needed.
Low-dose prophylaxis might be considered individually if you really can't find modifiable causes.
And treating asymptomatic bacteriuria.
Generally, no. Don't treat it routinely with antibiotics. Exceptions are pregnancy, before certain urological procedures, or sometimes with immunomodulatory treatments.
But it's a symptomatic UTI.
Treat based on urine culture and sensitivity results. Empirical treatment might be needed initially in severe cases. Usually a minimum 7-day course is recommended.
Any other non-pharmacological options?
Tibial nerve stimulation, either percutaneous, PTNS, or transcutaneous, TTNS, can be offered if other treatments fail or aren't tolerated.
Appliances.
Things like pads, diapers, condom catheters can help manage the social impact of incontinence for some. Specialist nurse input is good for condom catheters, but avoid external collection devices for overflow incontinence.
Okay, let's talk medications. Antimuscarinics.
They should be offered for storage symptoms, the overactive bladder picture. But you have to watch for anticholinergic side effects, constipation, dry mouth, blurred vision, drowsiness.
And cognitive impact.
Yes, that's a key concern. Always measure PVR before starting. Consider agents less likely to cross the blood-brain barrier, like trospium or darafenacin, especially in those at risk of cognitive issues.
What about beta-3 agonists?
They should also be offered for storage symptoms. They seem to have comparable efficacy to antimuscarinics, but potentially a better safety profile, fewer anticholinergic effects.
So maybe first line for some.
Could be considered first line, especially in people with cognitive disorders or in the elderly.
Any drugs to help bladder emptying? Cholinergic.
Unfortunately, there's insufficient evidence to recommend them for detrusor underactivity.
What about desmopressin for nocturia?
It may be offered if nocturia or nocturnal polyuria really hits quality of life, but you must restrict fluids after taking it.
Monitoring needed.
Yes. Monitor weight, blood pressure, and sodium levels. Use lower doses in the elderly, particularly women over 65, due to hyponatremia risk.
Lastly, alpha-1 blockers.
They could be offered for voiding symptoms that reduce urethral resistance. Big caution, though. They can cause hypotension.
Especially risky in whom?
Those with existing orthostatic hypotension, the elderly, high spinal cord injury, Parkinson's, dementia with Lewy bodies, or MSA. Advise taking it at bedtime initially, and mention ejaculatory dysfunction as a possible side effect.
That's a very clear run-through of urinary management. Let's switch gears to neurogenic sexual dysfunction. Assessment starts similarly.
Yes. Proactive, regular inquiry is key here, too. We need to explore the factors involved. Primary, that's the direct neurological impact.
Secondary.
Related physical changes, spasticity, fatigue, pain, incontinence.
And tertiary.
Psychological, social, cultural aspects. Self-image, relationship dynamics.
So we need to ask about desire, arousal, ED in men, lubrication in women, orgasm, sensation, ejaculation issues.
And ejaculation delayed, premature. Also dyspareunia, pain during sex, and always the impact on the relationship and well-being.
Important to be sensitive to sexual orientation, gender, relationship history.
Absolutely. Emotional state, substance use, past treatments, psychological issues, any history of sexual trauma, STI risk, and always review medications. Many can impact sexual function.
Stroke survivors, too.
Yes, inquire regularly. There are also validated questionnaires for conditions like MS and SCI that can help structure the conversation.
And the physical exam for sexual dysfunction.
Again, targeted and when appropriate. Vital signs including standing BP for orthostatic issues, neuroassessment, cognitive, motor, sensory, autonomic function, pelvic evaluation focusing on sacral dermatomes, sphincter tone, relevant reflexes like cremasteric, anal, bulbocavernosus.
Referral triggers here.
Suspected urological, gynecological, or endocrinological problems warrant referral.
What about lab tests?
In the right context, yes. Consider screening for vascular risk factors, fasting glucose, HbA1c, lipids, especially in men with ED.
Routine testosterone.
Not routinely recommended unless you clinically suspect hypogonadism. If you do test, a morning sample is preferred. Consider screening for urogenital cancers or STIs based on individual risk.
And more specialized tests. Neurophysiology, MRI.
Generally, no. Routine pelvic neurophysiology or MRI isn't usually needed for sexual dysfunction itself.
When might they be?
Perhaps in unexplained urogenital dysfunction where you suspect a neurological cause like atypical Parkinsonism or maybe unexplained female urinary retention, genital numbness. Or to clarify spinal MRI findings or after pelvic trauma, mostly specialist territory.
Okay. What are the red flags for referring someone for specialist sexual dysfunction care?
Referral helps avoid missing treatable conditions in complex cases. Key flags include pain or bleeding during sex and ejaculation, priaphism.
Anatomical changes.
Yes, suspected changes like penile curvature or plaque or pelvic organ prolapse. Also suspected endocrine causes like hypogonadism.
What if standard treatments aren't working?
That's another reason. Or if someone is seeking infertility treatment. Significant psychological issues like depression or anxiety or psychosocial factors like trauma impacting intimacy, these often need specialist input.
Moving to treatment strategies for sexual dysfunction, where do we start?
Education is foundational. Informing patients about how their neurological condition, medications, lifestyle factors like alcohol or diet can impact sexuality and intimacy.
Tailored to the individual.
Always. And involving partners when appropriate while maintaining professional boundaries, of course.
What about simple aids? Lubricants.
Vaginal lubricants may certainly be considered for dyspareunia or dryness in women. It's worth discussing. Types water-based can dry out, oil-based aren't condom compatible, silicone-based usually are. Consider local estrogen too, if appropriate.
Vibrators.
Discuss their use for arousal, maybe even erectile function in some SCI cases. Guidance on selection and safe use is important. Watch for contraindications like autonomic dysreflexia risk above T6 or skin breakdown risk.
Okay. Medical devices. Vacuum devices.
Vacuum erection devices can be offered, often as second line for ED in men. They can be effective but require dexterity.
And for women.
May be discussed for arousal problems, though evidence is more limited. SCI individuals might need a recumbent position. Limit constriction ring use under 30 minutes. Partner help might be needed. Caution with anticoagulants or bleeding disorders.
What about first-line pharmacotherapy for ED?
That's generally the phosphodiesterase 5 inhibitors, the PDE5 inhibitors.
Like sildenafil, tadalafil?
Exactly. They've shown effectiveness in SCI, MS in some studies, Parkinson's, but they do require some residual nerve function to work.
Side effects and contraindications.
Need to discuss potential headache, flushing, nasal congestion, dizziness, hypotension. Big contraindication is use with nitrates. Caution with alpha-1 blockers, too. Also contraindicated in certain retinal disorders, recent heart attack or stroke, very low BP, or when sex itself is medically inadvisable.
What if PDE5 inhibitors fail or are contraindicated?
Then prostaglandins, typically via intracavernous injection, are second line. Alprostadil is the usual one.
More effective in neurogenic ED sometimes.
Yes. Often high efficacy in SCI and MS. Intraurethral alprostadil is an alternative, less invasive, but maybe less effective.
Downsides.
Injection site pain, potential for penile scarring with repeated use, small risk of priapism, requires proper training by a professional.
Finally, addressing those Bladder factors we mentioned earlier.
Absolutely crucial. Regularly discuss and manage the secondary factors, spasticity, fatigue, incontinence, cognitive issues, medication side effects. Offer treatments for spasticity like baclofen or botulinum toxin. Advise on bladder bowel care before intimacy.
And the tertiary psychological aspects.
Assess and treat depression, anxiety. Promote positive body image, maybe through counseling. And always review medications if one is causing sexual dysfunction. Can it be adjusted or changed?
That covers a lot of ground. This deep dive has given us a really practical overview of the Ian Officinus NEUROGED guidelines for urinary and sexual symptoms in neurology patients.
Focusing on those assessment and treatment points relevant for daily practice.
And again, everyone, this was a summary for education. You absolutely need to read the full guidelines for the complete picture and nuances.
The evidence base for each recommendation is detailed there too.
Right. But proactively assessing and managing these urogenital symptoms, it can make such a difference to our patients' quality of life. Integrating these recommendations can really help provide more holistic care.
Definitely.
So perhaps something to think about is, which of these recommendations really hits home regarding the challenges you see in your own practice? What questions do they raise for you? We really encourage digging into that source material.